Welcome. This is a presentation for the Association of Air Medical Services Critical Care Transport Academy of 2023. The topic is going to be Myasthenia Gravis for the neurology module. Hello there. My name is May Praido. I'm a paramedic serving the Los Angeles County area. I'm also a member of the Los Angeles Fire Department disaster team. Also worked as a clinical lead for the Department of Health Services of Los Angeles County. I'm a third-year medical student for the critical care program of the University of Edinburgh and also an associate member of the Royal College of Physicians of Edinburgh. I have no disclosures or conflicts of interest. Let's get started. So what is myasthenia gravis? It's a rare neuromuscular disorder that affects primarily the neuromuscular junction process at the postsynaptic receptor, which results in muscle weakness. The primary cause is due to a chronic autoimmune disorder, but some cases can be genetic. Myasthenia gravis can also be associated with thymic pathologies, such as tumors, known as thymomas, or hyperplasia, that is the increase of size of the thymus due to inflammation. The congenital forms of this disorder, they're rare, and the pathology is going to be a little different, and they might not respond to the treatments. And myasthenia gravis affects women at a younger age and men at older ages. We're going to go over the two most common types of myasthenia gravis that you're going to encounter, especially in hospital setting. The first type is the acetylcholine receptor antibody-mediated MG. This is primarily caused by the antibodies, the AChR. They start to bind to the postsynaptic receptor. These antibodies can also bind to the MAC receptors, and it's a primary T cell and B cell dependent autoimmune response. So this type of myasthenia gravis usually affects the patient with generalized weakness, in particular on the limbs, the arms, the legs, the fingers, and the hand. So when the serology test is performed, they're going to come back with the acetylcholine receptor antibody as positive. So the second type is the MuSK-mediated myasthenia gravis. That is a muscle-specific kinase type of MG. The patient is going to test negative on the serology test for the AChR, so you would consider this type of test for this patient. Also, some of these patients might test negative for the MuSK-mediated myasthenia gravis, but test positive for the anti-LRP4 antibodies. This type of myasthenia gravis is more severe than the acetylcholine one, so the onset is usually within the bulbar innervated muscles, so it's going to affect the neck, the face, and the shoulder area. So why does this matter, and why is it important to know the difference between the two? Acetylcholine is important for muscle contraction, so when ACH is released, it signals for our muscles to contract. And that's where myasthenia gravis becomes a problem, and it can become a very dangerous disorder, because if this process is disturbed, the muscle despolarization does not occur, and it will direct affect the ability of those muscles to function properly. So this is particularly troublesome when affecting the respiratory muscles and the bulbar innervated muscles. So on this slide, let's go over how myasthenia gravis affect the body. When there is bulbar involvement, the patient is going to experience dysarthria, so the ability to speak is going to be compromised. Dysphagia, so it's going to be really hard to swallow. Even the ability to hold the head up, it's going to be compromised. And the pharyngeal muscles are going to experience weakness. When it comes to the respiratory system, myasthenia gravis can cause paralysis or weakness of the diaphragm. It can cause irregular breathing, and it can cause also a blunt respiratory response. And the main concern, it can cause respiratory arrest. For the limbs and body, it usually presents as a generalized muscle weakness. The patient is going to experience fatigue, and usually it gets worse with activity, gets better with resting, and is a progression. The patient feels a little bit better in the morning and worse at night. With ocular involvement, the patient is going to experience ptosis. It can also experience paralysis or weakness of the eye muscles. double vision, and trouble focusing. So as you can see, myasthenia gravis has a pretty broad effect on the body. But if you take a look on the first two boxes that I highlighted in red, these are the ones that we have to really watch for, and here is why. The exacerbation of the bulbar and respiratory involvements will lead to a myasthenic crisis. The patient can suffer respiratory failure and require intubation and mechanical ventilation. There is a high risk of aspiration for this patient. It can also lead to cardiac involvement, including the onset of ventricular tachycardia, heart failure, and sudden death. It's also good to understand what can trigger myasthenia gravis. As you can see over here, again, it's pretty broad. It goes from medications such as beta blockers, phenytoin, antibiotics, even statins, and procainamide, to general situations like infections, even pregnancy antibodies, menstrual periods, stress, or electrolyte disturbances. The treatments for myasthenia gravis is going to vary depending on the severity of the disease and the progression. Pyridostigmine and neostigmine, they might not be seen on the prehospital setting. Most likely they're going to be given in a hospital setting. The doses listed here are usually the recommended, but as you can see, there is a variation of the route and how much can be given. The same applies for steroids like prednisolone. Is usually a 10 milligrams starting dose every other day. It can go up to 100 milligrams, but again, that's dependent on the physician and the condition of the patient. Another common treatment you're going to see for myasthenia gravis is the IVIG, which is intravenous immunoglobulins. This is considered a rescue treatment with plasma replacement usually. The dose usually is 2 grams per kilo, and whatever amount it's going to be determined for the patient is usually split between 3 to 5 days. And also monoclonal antibodies can be given to treat myasthenia gravis. I think it's important to understand and discuss what we might encounter on the pre-hospital setting, working as a flight paramedic, a flight nurse, if you're doing ground critical care transport. Your clinical assessment is going to be really important. So focus on trying to recognize the signs of myasthenia gravis. We're going to watch for our ABCs, we're going to obtain vital signs, we're going to try to get an ECG, and constantly have this patient on a cardiac monitoring. We're going to obtain IV access and be very mindful of the position. Again, the patient might not be able to protect the airway and the patient is at a high risk of aspiration. So let's avoid supine positioning. And as we previously went over, if the patient is experiencing myasthenic crisis, it's very likely that this patient is going to require aggressive airway management, which is going to include intubation and mechanical ventilation. And as we are preparing to take that airway and protect it, we have to understand a few concepts when it comes to your RSI, DSI medications, and why that can become a pitfall in myasthenia gravis. Your induction agents are going to remain the same. You can use ketamine, etomidate, propofol. There is no change on the dosage here. For the paralytics, we should approach as follows. Rocuronium is going to be our preferred paralytic agent for myasthenia gravis or myasthenic crisis. As we discussed on the pathophysiology of myasthenia gravis, even though this is a non-depolarizing agent, it's going to have its potency increased because of everything that is going on with the postsynaptic receptor. So we're going to use half of the usual dose. So instead of us giving 1 milligrams per kilo, we're going to be giving half milligram per kilo. Considering that succinylcholine is a depolarizing agent, we have to understand because there are less postsynaptic AChRs, like the acetylcholine receptors available, it's going to be less effective. So for succinylcholine, if you don't have rocuronium present, we're going to double the dose. So instead of us giving 1 milligram per kilo, we're going to approach with 2 milligrams per kilo. When it comes to ventilatory support, we have to understand that 90% of the patients experience a myasthenic crisis will require intubation and ventilatory support. If we can, we should also obtain a chest x-ray after intubation. It's very important for patients with a myasthenia gravis to have their vital capacity evaluated. And here's why. If this patient has a vital capacity of less than a liter, which will come to 20 to 25 milliliters per kilo, and has a negative inspiratory force of minus 20 centimeters of water, those are strong indicatives of significant respiratory weakness. And if the positive expiratory force is less than 40 centimeters of water, this is a strong indicative that this patient is experiencing a crisis. When it comes to non-invasive ventilation, we have to take in consideration that even though it can be used, this patient is at a high risk of aspiration. And most of the non-invasive, they're not going to protect this patient airway against aspiration. So intubation still remains the gold standard for the management of the airway. Some of these patients also might require a trach. Again, they lost the ability to maintain the airway, those muscles. And when we are weaning the ventilation out of this patient, getting out of the ventilator, we should be also very mindful to make sure this patient can support a proper ventilation. So there has to be an improvement of at least 15 centimeters of water underneath. And last but not least, let's discuss a little bit of differential diagnosis. So myasthenia gravis can have several differential diagnoses with similar clinical presentations. Again, your clinical assessment might play a strong role in deciding the course of treatment for this patient. Again, in the prehospital setting, you're not going to have the serology test available to see if it's acetylcholine, if it's a MuSK. And again, it's important to understand what other conditions can present with similar signs and symptoms. I would strongly recommend going over some of these disorders and diseases presented here and see how they have similarities and what can be the little differences that we can use in our clinical assessment. Even though this is a small presentation about myasthenia gravis and myasthenic crisis, I hope you were able to learn some key points about this disorder, and I appreciate your time. Thank you.